started in introducing Dr. Pettus and the last presentation of the day. So my name's Madeline Nolan. I'm actually a fourth-year medical student at the Northern Ontario School of Medicine, and I've had the absolute privilege of working with the planning committee over the past few years, learning everything from what it takes across the region to deliver palliative care to individual tips from Dr. Pun in the hospital, and it's been a real privilege. So I'm very honored to be here today to listen to all of the presenters and to introduce Dr. Pettus. I just wanted to quickly touch on the housekeeping items that I'm sure you're all acquainted with, but just to keep yourselves on mute throughout the presentation. We will be posing questions at the end of the presentation, those that are put in the chat, so you can feel free to comment throughout the presentation or at the very end, and I'll be sure to share those questions. So without further ado, I'd like to tell you a little bit about Dr. Katherine Pettus, who is currently the Senior Advocacy and Partnerships Director for the International Association for Hospice and Palliative Care. Dr. Katherine Pettus holds a PhD in political theory from Columbia University and a master's degree in health law and policy from the University of California, San Diego. In her capacity as a Senior Advocacy and Partnerships Director, Katherine attends UN organization meetings to advocate for improved availability and rational use of opioids for palliative care as a component of the right to health. She addresses issues of global palliative care development and policy, especially those affecting older persons, as an element of universal health coverage throughout the life course. Her full bio can be found on the IAHPC website at hospicecare.com, as well as the conference website. And I am looking forward to hearing her presentation on palliative care for all who need it in a world free from health-related suffering. So thank you very much, Katherine.
Can you hear me? Can you hear me? Okay, yes. Great. I'm going to share my presentation. Hopefully it works.
Yeah, just make sure you optimize for audio and video, Katherine.
We'll try. Sorry about that, everyone. I need to get back to the beginning. Right. So I have to start with the speaker disclosure. The session title, as Madeline said, is The Palliative Care for All Who Need It in a World Free from Health-Related Suffering, and that should be health. Mistake. I am the speaker. I have no relationships with financial sponsors, no disclosure of financial support, and my potential for a conflict of interest would be that I've authored books related to palliative care services and advocacy, and all proceeds from the sale of my book, Global Palliative Care Reports from the Peripheries, are donated to Hospice Africa, Uganda. So I acknowledge that I'm speaking to you from the traditional lands and waters of the Tiwa people of northern New Mexico, also known as the Red Willow people, who sustain us spiritually and physically in our everyday lives. So I thank them, and this is Taos Mountain. That's my title slide, and I want to thank, actually, I'll go back to the title slide because I want to thank Monica Dakuto-Mani and the organizing team of the conference for giving me the opportunity to share with you these glimpses of the global palliative care movement and how the Near North Palliative Care Network is part of that movement and how I believe that movement is changing the world. From the peripheries to the center, from the macrocosm to the microcosm and back again. And the microcosm in this sense is the IDT on the ground. of course, I also want to thank the audience for being with us all here online and for having hung out with us all day. I've been with you since 6:30 in the morning, my time, for all the great presentations I've heard. Because what you're doing is creating this world free from health-related suffering. Your work at the bedside is like stem cell therapy for the polity, not to cure, as you know, but to heal, which is an idea that I hope will inspire you more once I make this a bit more clear about this macrocosmic level. So the IDT, as I know it from some of my work in San Diego, may be a full team or in Africa, just like one nurse who I've gone out with, that she's the IDT at Hospice Africa Uganda. This is Nurse Joyce, who you can read about in the book, and who took me on home visits in lots of different communities. So we're actualizing a collective vision, what the Lancet Commission on the Value of Death called a realistic utopia. And your work as palliative care practitioners, administrators, policymakers is building that realistic utopia as we speak. So the first thing I'm going to do is define serious health-related suffering, since that's one of the learning objectives. Then I'm going to tell a bit about my story as it relates to serious health-related suffering and to this presentation. I'm going to talk about IHPC, the organization I work for, the International Association for Hospice and Palliative Care, and the global movement, some challenges that we're facing, and the transformative potential of palliative care, which I've already referenced. And maybe we'll get to the Palliative Care Peace Corps, which is an idea I float in my book. So serious health-related suffering is associated, this is the definition that's on our website, it's also in Palliapedia, it's associated with illness or injury of any kind that's health-related. It cannot be relieved without medical intervention, and it compromises physical, social, spiritual, and or emotional functioning. And serious health-related suffering was introduced in the report, this concept of the Lancet Commission on Pain Relief and Palliative Care in 2018. So you've seen this, the basic definition. It gets quite a bit more elaborate, but I'm not going to go into that. And we have published a new definition of palliative care, which is a consensus-based definition. It was published in 2019, based on this concept of serious health-related suffering, because emphasizing suffering as a mainstay of the new definition, and that's not in the WHO definition, it allows a shift from disease-based treatment or a disease-centered conceptualization to a more person-centered conceptualization and approach to palliative care. So the definition thus recognizes that palliative care should be delivered based on need rather than on prognosis. And this definition has been endorsed by more than 190 associations and organizations and 1,000 individuals, at least around the world. So this is a 2019 definition, where the WHO definition was a 2002. I think I got that right, or 2000 definition. So it's 20 years old or more. So I borrowed this slide from a colleague in Trinidad and Tobago who shared it at a meeting of the Commission on Narcotic Drugs last year. It's just one example of serious health-related suffering, which you're all familiar with from your work. So this is in the vernacular of Trinidad and Tobago, and he says, her whole body was in pain, and then plays a phone recording of a woman screaming in distress. I've heard the same thing from colleagues in Sudan and from all over the world. Yeah, day and night, real pain, all 2, 3 o'clock in the morning, within wake and sleep, I hearing my mother bawling the place down. Yeah, I'm sure, as I said, you're all familiar with this. And these are quotations from the son of a Trinidadian cancer patient. And it also shows, of course, the burden on the caregivers. So these are the statistics on serious health-related suffering, that more than 80% of the world population has no access to pain relief or palliative care. 61 million of those people are in serious health-related suffering globally, and 50.5 million, so nearly 90% almost, looks like it, in low and middle-income countries. And that's the reference, which is the Lancet Commission, Alleviating the Abyss. So, as I said, I'll start with my personal story, which for the purposes of this event began with the death of my mother, who you see on the screen as a young woman, and who died of colon cancer with no palliative care at home, age 51, with me, a 19-year-old at that time, with no experience of serious illness or death, sitting vigil by her bedside all night while she labored to die, having been given a massive dose of morphine by a doctor friend of my father's, who came in the night, went into her bedroom, shut the door while the family waited outside because we'd been called, and eventually came out to tell us, quote, "She won't wake up now." Then he snapped his bag shut and left, but not before he'd answered my rather panicky question, what happens if she does? And he said, well, you'd better hope she doesn't. Needless to say, we had no clue what to expect, never having been told, having no support from a clinical team. I sat with her all night, and she died at dawn with a joyful smile on her face after what seemed to be a really terrible, dreadful struggle every breath. The thing was, I didn't learn until much later that it doesn't have to be like that. Although it is like that, and much worse, with no morphine in the rest of the world, which is what I call the peripheries. So palliative care was non-existent in Washington, D.C., where this was in the early 1970s. I had flown over within 24 hours. I was in Australia at the University of Sydney finishing my degree, and I knew my mother was sick. But they finally called to say, you better come. So I came. And they were stationed there. My parents were both, well, my dad was a diplomat. She was a diplomat's wife. And he'd taken leave to take care of her. And the nurses who came once a week to see my mother had her on a strict schedule of Dilaudid injections every 4 hours, given by my dad and younger sister, who'd practiced on oranges. No allowance was made for breakthrough pain from her bone mets and from the liver cancer. And the day before the doctor came in the night, like Nicodemus came in the night, but this doctor came to administer the fatal dose of morphine, my mother had asked my brother while she was conscious, my older brother, if he could get her some heroin or morphine on the street in Washington, D.C., because the Dilaudid wasn't touching the pain. And she was the wife of a U.S. diplomat asking my brother to put himself in danger to go and get heroin for her. He couldn't fulfill that request, but since I've been in this business, I've heard lots of stories like that, especially in countries where getting street drugs to control pain because pharmaceutical preparations aren't available can result in the death sentence or long jail sentences, prison sentences. So what I learned more than 30 years later as a student of health leadership and a hospice volunteer in California was that serious death and health-related suffering, serious illness and health-related suffering and dying can be properly addressed and professionally attended, and that families can be supported, unlike us, and that patients can have their pain controlled. And as soon as I heard that, I wanted to join the movement so no other families would have to suffer as we did, watching our mother die in terrible pain and then being abandoned as a family with no grief support. But I found out to my horror, as I pursued my studies, that more than 70, 80, 90% of the people, these are all estimates, but it's almost the whole amount in lower and middle income countries, still lacked palliative care. When I went to a global conference in Fresno, California on health leadership in lower and middle income countries, and I met Dr. Roger Gopal on the right and Dr. Anne Merriman at the center on the left, for the first time, the leaders from Africa and India who became my mentors and still are. They're developing palliative care on the peripheries for the poorest of the poor, for those who otherwise are abandoned by health systems. They are literally lighting the way. So long story short, I went back to school. I got my master's in health law instead of health leadership, and did my thesis on the international drug control treaties and access to controlled medicines. So I knew there was story. But astonishingly, the dean of the international law faculty in California, where I was, and the textbooks we used, the dean didn't know about the international drug control conventions, and they were not listed in the textbooks we used. So I was really flying blind and doing all the research on my own. But these things affect millions of people around the world, and they're not studied. Opioids were then and still are the third rail of American politics. And the international drumbeat is finally beginning to change, at least it did until the North American opioid crisis, with the participation of affected populations in global meetings, speaking for themselves. And in this case, these are populations with little or no access to palliative care medicines such as morphine, which people like us now take for granted. And this map, which many of you are familiar with, shows the global pain divide, which the Lancet Commission on Pain and Palliative Care estimated using opioid estimates that are submitted to the International Narcotic Control Board. So that's a proxy for the amount of palliative care. This map is about serious health-related suffering based on availability of opioids. You can see the bloated continents, which have an excess supply related to need, and all the skinny countries in the rest of the world, except for Western Europe, which have way below what they need. It's just an approximation, but they've done the math on this, they've done the calculations, and this is the inequity or the global abyss, as it's known, in access to pain relief. So it's what I call the cartography of pain. And I really name it in my presentations as an issue of inequity, which I'm going to get into later. But for now, we're going to watch a short video on the topic, which has to do with our advocacy to change this map. It's about morphine.
Hi, Catherine, there's no sound playing on our end.
I'm sorry, what was that?
I don't hear any sound playing on our end of things.
Oh dear. What do you suggest I do?
I would stop screen sharing and then reshare and just make sure that that button was clicked for optimize for motion and video.
I'll try again.
If not, I can take over if needed.
Okay, right. We'll go to plan B. Try again.
No, I still don't hear anything. Did you want me to share it?
Is that good or not?
No, I can't hear anything. Did you want me to share it?
Oh, yeah, because that button was pressed. Okay.
Okay.
people have perceived that pain relief is a luxury that we in developing countries cannot afford. And I would challenge that quite vigorously, because I think it's an absolute essential for many reasons. But there is that perception, you know, it's only for the people where in the countries that have everything else in place. And we have epidemics to fight. You know, we've got tuberculosis or HIV or other epidemics. So again, it comes back to the point where we have to place it in a context and say that, yes, all of these illnesses, and we have to be able to prioritise, but we have to put pain back onto that agenda.
So this is the product that at the end of the day all the hard work goes into, which is morphine, been around for 2,000 years. Still considered the gold standard in pain relief. The best part about it is all the hard work's done by nature.
It is one of the cheapest medications that we could have.
To give you an idea just of the potency, here's approximately 5 grams here, and that would be able to give a therapeutic dose of around about 250 to potentially 500 people.
All other pain medication in the country, I mean all other, including the cheapest paracetamol, all other medication are more expensive.
We can do a therapeutic dose for under a cent.
In my country, at some point in 2002, I think the expenditure, government expenditure on health was $72. Now, if you add on the cost of morphine per patient to ensure pain control, it won't even reach $75.
We know that it's not a matter that we need to invest a lot of money inventing new drugs. We have it.
Maybe it was more expensive. The industry would be more interested in it.
From a pharmaceutical company standpoint, there's no money to be made in morphine. So what they want to do is bring in expensive, fentanyl patches or some technology, and that way they can make money.
Many hospitals in our country have transdermal fentanyl, but not oral morphine. Because it's expensive, the profit margin is better.
So unless you can figure out a way to bundle it with other drugs, you can't get pharmaceutical companies to import it or manufacture it.
Fortunately, Cipla, one of the Indian pharmaceutical companies, as a charity measure, is making it at no profit. So it is available at very limited cost. Something like 12 cents of American money would give a day's pain relief for an average patient.
In a country like Jordan, what we found was that fentanyl patches were available to anyone who could buy them. But buying a fentanyl patch was a nursing salary for a month. So availability and access are two very different things. So there was a major effort to make oral morphine available, to develop, in fact, a pharmaceutical company there that would make this, and to make it more widely available for cancer patients in their National Cancer Center. And this has now happened. So the patients who could have never paid for a fentanyl patch now have oral morphine available.
It's professionally satisfying to see like somebody was in pain for the last 3 months and suddenly he starts smiling.
Okay.
Did you want to take back over the screen sharing, or did you
No,
want me to
I'll do it if it works, hopefully.
Yeah.
Let's go back to play from current slide. Right. So now it's time to transition to the more technical part of the presentation. This presentation's like a 3-course meal. We just had the appetizers, this is the main, and then we'll have a dessert. But this part is about the International Association for Hospice and Care and about advocacy and why advocacy at the global level is so important. what we've accomplished in a relatively short time, and the many challenges that lie ahead. So I'm sure I'll leave lots of gaps because there's lots of ground to cover, and you'll have questions. So please write them down and save them for discussion, put them in the chat, and I hope we can have a discussion at the end. So my title is Senior Advocacy and Partnerships Director, because our advocacy work is mainly about building partnerships with governments, other NGOs, UN Secretariat staff, and national palliative care associations. One of our strategic plan goals is to help build a global social movement for palliative care, which of course, as I said, you're all a part of. So first of all, what is IHPC? We're a global nonprofit membership organization headquartered in Texas, Houston, Texas, in the USA. Our vision, as you can see from the slide, is a world free from health-related suffering, hence the title of my presentation, where all people with palliative care needs get the services they need. And our mission is to serve as a global platform to inspire, empower, and to inspire, inform, and empower individuals, governments, and organizations to increase access to and optimize the practice of palliative care. And we do this through our 4 pillars, which are advocacy, education, research, and information dissemination. So you can see we're a global membership organization with individuals and institutional members, so please join us. We're in 108 countries at last count. We have 12 advocacy focal points, including, of course, your executive director, Monica Dakuta-Moni, and 5 leadership development grantees in Albania, Burkina Faso, India, Colombia, and Zambia. Our membership fees are on a sliding scale, pegged to the World Bank classifications of countries, and the majority of our members are in North America and Asia, with practitioners who are members in the wealthier countries supporting our work to provide education and scholarships to practitioners in lower resource countries through their memberships. This is solidarity, mutual and shared responsibility. So our preferences for scholarships to conferences and global educational gatherings is for practitioners from lower and middle income countries, since they have fewer educational opportunities in those countries. And this presentation is based on the advocacy pillar of our work instead of the other 3, since that's where I've been focusing for the last 8 years. So first, let's look at a working definition of health advocacy, which according to this particular one, the American Journal of Public Health, says it's the process of gaining political commitment for a particular goal or program identified by some as a critical population health strategy. And many have identified palliative care as a critical population health strategy. As the presentations this morning made clear, COVID also made that a critical population health strategy. So my work at the global level is to gain political commitment from lots of member states who gather at multilateral gatherings. So this is what we do. We get the word out, we share the vision, we evangelize, we spread the good news to governments about palliative care. Advocacy is an institutional activity, unlike activism, which can be done by individuals or non-registered activist groups. And I'm going to talk a bit about our advocacy program in the hope that you might consider joining the team, as dear Monica has, and share. We participate we identify and cultivate common ground, as I said, with partners, and we participate in governance by sharing evidence and stories. And by governance, I mean at the world level, at the global level, through the UN organizations. We at IHBC don't participate in national governance, but we educate the people who are participating in national governance. So IHPC and our members are authorized to advocate at all levels of governance, at the global, regional, national level, and the patient and family level, because the United Nations recognizes the importance of partnering with civil society. That's us, because doing so advances its ideals and helps support its work. Global health doesn't have a line item, so to speak, for palliative care. We're just getting a foot in the door. The aim has always been to cure disease, and little thought has been given to what happens to the millions of people whose diseases can't be cured, and yet whose quality of life can be improved considerably by palliative care. This is an issue of global health ethics, as well as clinical development, education, and research that provides the the evidence base we need for advocacy. We identify, as I said, and cultivate common ground. I'm not going to go over that again. So we're officially accredited, as I said, to work at the global level and to advocate at the regional level. The UN High Commissioner for Human Rights recognizes the work of advocacy as supported by the rights of freedom of expression, assembly, and association. And those freedoms alone, of course, don't ensure that anyone will listen to us just because we have those freedoms to do it. They have to carry a compelling message, bringing the bedside to the boardroom, so to speak, the voice of the patient and the practitioner into the halls of power. And in order to do this, we have to be officially accredited and have an organizational structure, pay taxes, fill out reports, all those things that you know about. So the UN Economic and Social Council, that's ECOSOC, that's the acronym, accredits us to work with all their agencies, and the World Health Organization, which is a slightly different UN agency, accredits us to work with them as a non-state actor in official relations. So that's under those auspices what I participate in. And WHO, for instance, we work with the essential medicines of palliative care that are now included on the model list in section 2. And we're now working as part of our being in official relations on a compendium of formularies and best prescription practices for those medicines. So they're not just listed, we have a compendium of practice and formularies. So our role with WHO is both technical and normative. By normative, I mean that's the participating in governance saying this should be done based on the human rights, based on the international law that exists. Palliative care may be the new kid on the block, but needs to be included. So we engage with those member states and with the Secretariat at intergovernmental meetings. That's where Canada participates too, of course, such as the World Health Assembly. And with ECOSOC, we work at the Commission on Narcotic Drugs, which I'll get to later, and the Open-Ended Working Group on Aging at the United Nations. So our advocacy ethos mirrors the ethics of clinical practice, which center on non-abandonment of the patient. So we don't abandon, we include the voices of all impacted populations, especially those who, as I said at the beginning, are on the existential peripheries, the furthest reaches, who most health systems invisibilize and therefore abandon. We promote the ethic of mutual and shared responsibility, which is actually a UN principle. It's an articulated UN principle that means, in effect, that we encourage governments and associations and partners to bear one another's burdens, from funding to assisting with policy, assisting with education, assisting with technical needs, etc. We are in solidarity with those who suffer, and we collaborate often with partners we would not otherwise consider in order to bring patients and families the care they need. And here, in the infographic from the World Health Organization, produced as a result of our advocacy, is why we advocate, because of the global gaps in palliative care. And this is why the palliative care movement is global, because the statistics we see, the 86% of people who need palliative care but don't get it, the 83% who lack access to pain relief, according to WHO statistics, the 98% of children needing palliative care living in lower and middle income countries. This shows a global problem. And it's why the WHO calls palliative care a global good. And the laws and norms governing the right to access healthcare and palliative care medicines are global. Those international laws are global. They've been committed to by all your governments. And this calls for a global coordinated response. So our advocacy at the IHPC works to create a living circuit or feedback loop from the microcosm, which is the bedside, from our global membership, who are mostly practitioners, our staff, through our advocacy focal points, to global national decision makers and technocrats, through IHPC communications, to national and regional palliative care associations, to national and subnational legislators, and then back again to IHPC members and practitioners, serving IHPC research, education, information, always with the patient and family at the center. So I'm not very clever doing these kinds of infographics. I wish I could have someone help me do them, but it's supposed to show a live circuit of our work and how it actually goes one way and then it goes back the other way. And it's constantly being updated on social media and reported on monthly in our newsletter. Oh, see, IHPC communications, I should have done that before. So our advocacy that's focused on informing member states who tend to listen to one another rather than to us concentrates on educating the delegations to UN meetings, working with the secretariats, as I said, and the diplomats to ensure, who are mostly foreign affairs diplomats, they don't know anything about health. So we have to educate them to ensure that palliative care is included in what's called the agreed language of UN documents relative to public health. Agreed language is like precedent in law. So we need to establish it, because if we don't establish it, we can make progress on one front and then we lose it on the next front. We have to establish a thread of language and narrative. So that's part of my job, is to make sure the words are in there. So we try to create a global consensus affirming that governments should develop and fund national policies and training programs, and that opioid phobia in the 21st century is outdated and uncalled for, with a well-educated health workforce, robust regulations around pharmaceutical company misbehavior and practices, robust supply chains for generics that are shorter than they have been and are secure. So many governments, as you know, and we heard all morning, sideline palliative care during COVID just when it's needed most, and only advocacy will change this and make pandemic preparedness part of all national plans that include palliative care. One of the key advocacy topics we're working on now is to ensure that palliative care is included in any pandemic response and preparedness treaty that's being negotiated by WHO at the moment. We feel like we've had a win when a government representative actually says the words during a World Health Assembly or other UN meeting. And I've been monitoring the World Health Organization Executive Board meeting that's in Geneva because we prepared that through our advocacy focal points. And our delegate who's there texted me that Argentina had said palliative care during the debate because they had been prepared for it, because there's an agenda item on palliative care for disabilities, for people with disabilities. There's a resolution that's being debated, and we wanted the member states to include palliative care in their statements on the resolution, and it worked, at least with Argentina. So these are our global wins since 2014 and the World Health Assembly resolution, Palliative Care Resolution 6719, which is a framework agreed to by all WHO member states to integrate palliative care as part of primary health care and universal health coverage. The second one is the UN UNGAS document, Chapter 2, from 2016 on palliative care medicines. We had a whole chapter out of 7 chapters that reframes the drug policy narrative on access to controlled medicines and makes it a domestic priority. And again, all UN member states approved this document. The third one was 2018. Palliative care was added to the Astana Declaration, which updated the 1978 Alma Ata Declaration on primary health care. Palliative care was not included in the Zero draft that was updating the Alma Ata Declaration. It stopped at rehabilitation. We made sure palliative care was included, and there are 2 references to it now. The political declaration on universal health coverage approved in 2019 at the UN also did not include palliative care in the Zero draft. Through our advocacy, it now does. And then we had some groundbreaking civil society dialogues with Dr. Tedros, the Director General of WHO in 2020 during the pandemic, global virtual dialogues. So why is this important? Because if the language isn't in these documents and the leadership doesn't get how important it is, they won't support the policies and they won't fund them and they won't endorse the training and the credentials that you all need in order to build the infrastructure of this palliative care movement. So that's why we have to have the language in the high-level documents. So our advocacy creates a feedback loop from the bedside to the UN entities and then back again. I hope that's clear from this, but if you've got questions about it, please do ask them, because it's complicated. It hasn't really been done before. We in the beginning, we were just making it up as we went along. So we had a big win last year, 10 years after I first took on this work of advocating for controlled medicines, or to use the system language, those substances containing narcotic drugs. The Belgian ambassador was the president of the Commission on Narcotic Drugs last year, and he made access to medicines his focus of concern as part of the treaty obligations of member states. He held high-level events with the chair of the International Narcotics Control Board, the Director General of the World Health Organization, the Special Rapporteur for Health from the Human Rights Council, and several ambassadors from high and low income countries. I don't believe we've ever had such high visibility except during the negotiations for the UN General Assembly on drug policy, which got us that separate chapter, and we accomplished a lot on that one. So here's a short video made by the UN Office of Drugs and Crime, the Secretariat for the Commission on Narcotic Drugs, for social media. It was shared widely and hopefully raised some consciousness of the issue. So I'm going to stop sharing, Melissa, so you can undo it now, and we'll do our little dog and pony show again.
For sure.
Okay.
The initiative No Patient Left Behind aims at ensuring that everywhere in the world,
patients who need painkillers or narcotic drugs for their medical condition can have a better access and availability of these drugs.
It's necessary to improve access to controlled substances for medical and scientific purposes, because without that access, people suffer in terrible, what's actually preventable pain. And it's not just for pain and palliative care. These are essential medicines on the World Health Organization model list. So they're supposed to be available in every health system in the world.
As we work to address this global problem, it's critical that we position public health and human rights at the center of the international drug policy dialogue.
The call we have launched this afternoon aims at raising the awareness of the problem and also engaging the international community in addressing the problem and making sure that these medicines are better available and more accessible to countries where they are for the moment not or hardly available.
So now the member states need to step up. So it's not just charities, and it's not just if you're lucky enough to have funding. It needs to be part of a health budget, and it needs to be part of a balanced drug control policy.
In times of crisis, we must live up to our common and shared responsibility to support those who need help, treatment, and protection as a result of the world drug problem.
Now you're going to see a short video with the leader of another UN agency, the World Health Organization, that Dr. Tedros made for us, for IHPC, when we invited him to welcome the audience on World Hospice and Palliative Care Day in 2021 at an event that we co-produced with the UN University Global Health Institute in Malaysia. These high-level documents, these high-level endorsements, authorize all the work you do and are intended to encourage national governments to take meaningful steps to ensure access to palliative care and medicines in the public sector. So after this video, I'm going to close with the last part of the presentation, which looks at how palliative care is an evolutionary force. So, Melissa, it's all yours. Take away the next video.
Dear colleagues and friends, in 2014, the World Health Assembly adopted a landmark resolution on integrating palliative care as an essential service as part of every country's journey towards universal health coverage. Since then, we have made some progress. More health professionals have been trained, and new initiatives have been taken to integrate palliative care into different levels of care. But millions of people still lack access to essential services or essential medicines for palliative care. Addressing these challenges requires stronger multi-stakeholder collaboration to integrate palliative care into health systems in all countries. It means adapting health policies to the needs of people, measuring the impact of palliative care interventions, and working together across sectors and across borders. Recently, I wrote to all heads of state about the importance of ensuring access to palliative care and offering WHO's technical support. As we mark World Hospice and Palliative Care Day, I hope this meeting will be an opportunity to agree on urgent action and stronger cooperation to ensure that every year more people have access to palliative care with compassion, respect, and dignity when they need it. I thank you.
Try again. Share. Oh, worked that time. Oh, well. So the Jesuit, now we come to part three, the dessert. So the Jesuit theologian and paleontologist Pierre Teilhard de Chardin defined evolution as the universe becoming conscious of itself. Having participated in palliative care as a caregiver and a hospice volunteer before I became a policy advocate, and having observed practitioners delivering care in many settings, especially very poor settings, I see palliative care as an evolutionary force because it demands, remember the definition, that practitioners become conscious of themselves in order that they may be properly vulnerable to the vulnerability of the other, which is another definition by a religious historian called John Caputo, but I'll get into that in a minute. By definition, becoming conscious of oneself requires the courage to be with, to live into the truth of suffering, no matter how unpalatable or with a hyphen, graceful, as suffering is often conceived as disgraceful. Only then can suffering be transformed, alchemized, and healed by grace, which is etymologically related to gratitude. And I mention gratitude because I was part of a home visit that I show in these photos, which I took in Uganda in a visit to a very poor informal setting, informal settlement, or what we used to call politically correctly, apparently, slums outside Kampala, where we began with an outdoor visit. And you can see the patient here and Nurse Joyce here, and the gentleman on the right is Dr. Ephron, who's a medical officer from Ethiopia, who was visiting for some more training to Hospice Africa Uganda. This gentleman had a very bad cancer which had metastasized of his private parts and was otherwise abandoned by the health system. So we had the first beginning consult, the sort of social work. How are you doing? What's happening? What's going on? Part outside because the hut itself was so stuffy and hot. And then we went into the hut and did the medical work, where Joyce prayed with the patient and his wife in Luganda, their local language, and ensured all their basic needs, that they had enough oral morphine and everything was met. And at the end, the patient who is here started to cry. And when Joyce asked him why, he responded that it was because he was so grateful that we had visited him, that he had no conception. If you can imagine living in this enormous sprawling slum, you can see the trash outside. There's no water, there's no running water, there's no electricity. And he just said he felt extremely unworthy. He'd been shamed. And we brought light into his hut, into his very dark dwelling. And his gratitude was just overwhelming. It brought us all to tears. I'm going to cry again now. So palliative care's stance of being comfortable with the unknown leads to the development of confidence, resilience, and empowerment in patient and families receiving the best care, such as this child with serious disabilities in a very poor barrio in Panama, who's being examined by a nurse. Again, we had to park quite a while away and then walk because the roads were no good. But, you know, that's where these teams go, as I said, to the peripheries. And the fact that we're all vulnerable, all subject to suffering, old age, and death, makes strategies of death avoidance through domination and control, like the global system wants to do, both futile and painful for all parties, particularly those who are outcast by serious illness. An individual, patient's, families, or community's capacity to embrace the unknown as they face serious health-related suffering, together with a palliative care team, is transformative and evolutionary and supports the change of heart, or the metanoia, to use the Greek word, that policymakers need to incorporate palliative care into primary health care. They're not going to do it if they don't have that metanoia. To make the palliative care choice, to make the political choice, I should say, for palliative care that Dr. Tedros insists on, requires metanoia, or ethical accountability may be another more accessible word for serious health-related suffering, that policymakers take ethical accountability for it. And back to the word again, metanoia, according to religious historian John Caputo, means, quote, to change our heart, to become merciful to a fault, to let ourselves be touched and besieged by those who are under siege, to be overcome by the power of their powerlessness. Metanoia means to grieve over mercilessness and to succumb to the demands of mercy, to let oneself be touched, to be affected by the claims of the flesh laid low, unquote. This is not just a private transformation, but in our case, we're asking for a public transformation, one that requires active citizenship. And I interpret palliative care practice as active citizenship that exemplifies the ancient virtues of courage, the ancient virtues of citizenship, namely courage, friendship, prudence, magnanimity, and greatness of soul. Believe it or not, those were considered virtues of citizenship during the classical age from the people who invented the democracies and republics we now purport to live in. So a central virtue of citizenship is what Aristotle called truth-telling, or parrhesia, to use the Greek word. Second, and directly related to truth-telling, palliative care both expresses and generates friendship, as you see in this picture, in the classic sense of philia, or, quote, a loving bond involving altruism, reciprocity, and mutual recognition, unquote. If these ethics of truth-telling and civic friendship can seep from palliative care practice at the bedside into the public sphere, they can be a healing and regenerative political force. And one reason I think palliative care practitioners value the virtue of truth-telling so highly is that they practice in the shadow of death, the end game of physical mortality, a worthy opponent whose proximity, by definition, defies dissimulation or avoidance. This practice in proximity to death calls forth, in some practitioners at least, another core virtue of citizenship, which is courage or fearlessness. Palliative care practice does not try to prolong life, and that's part of the definitions. Excuse me. It doesn't try to prolong life artificially to cheat death. It meets death respectfully in order to benefit the friend or the patient traveling towards it. Those virtues are the very marrow of the bones of citizenship that support the rights of palliative care, the political rights, the political, social, and cultural rights modern citizens take for granted and rarely use. Those are the rights that are inscribed in the international human rights laws. So tentatively optimistic, I believe that grafting the ethic of palliative care into existing regimes of international and domestic law will enable them to bear nutritious fruit. Policies that actually do promote the common good. As such, palliative care is a praxis that equips individuals and communities to participate in our collective evolution, enabling us to better solve other pressing problems such as climate change, species lost, global poverty, migration, and so on. I don't have time to go into more detail on this, but maybe we could have a discussion on it if it interests you. And I love this last photo from my first visit to Uganda with the hospice team, to see this woman's husband who was lying on the dirt floor of their hut, literally a circular one-room hut, and could not move. He was just lying there. He was just completely moribund, basically. And for once, we had a physical therapist with us in the van. And I thought, because I was a newbie at this point, I had no idea, why would a physical therapist go on a palliative care team? Well, I saw. So we had a physical therapist with us, and he showed them some simple exercises to get the patient sitting up so he could eat, because his wife couldn't properly feed him when he was lying down, stretching and exercising a bit. It was literally like a miracle, like Lazarus walking out of the tomb. And this woman gave me one of her homegrown pumpkins as a token of gratitude that symbolizes to me our cosmopolitan palliative care. So our challenges for this year include building on the momentum gained, which I've given you a glimpse of, especially in the very fragile international context we're all living and dying through, the global cost of living crisis, COVID, and hopefully recovery, the climate crisis, disinformation, the opioid crises, the crisis of excess and the crisis of not having any, and the very well-funded global euthanasia movement. We have to continue awareness raising, promote evidence-based research, particularly in low and middle income countries that get about 1/10 of the publications the upper income countries get, and make sure our advocacy addresses the global situation, which means participating in disseminating the global 2030 Agenda for Sustainable Development. So we have a lot on our plate and very little funding, but an indomitable spirit and a desire to build trust and partnerships to overcome these challenges. So thank you for your attention after such a long day. And we can finish off with a short video from my friends at Moonshine Productions. Take a stretch and come back for Q&A if you're still in one piece. So I'm going to stop sharing and give it back to Melissa for the final video and be standing by for your questions.
It's a world that needs a remedy, one world, one true solution for people crying out in pain. Life and death, one resolution. There are souls who lie in vain. All their voices call our names. How do we bring on changes while tears fall down like water? We all belong to. Sweet relief, take away the pain inside me. Give me one last dance with peace. Goodbye kiss to friends, to family. Is this how the story ends? I know we will meet again, where there's nowhere left to be running. We all belong. We all belong to. We all belong.
as I look around the world, I see that about 1 billion people in the world have access to decent pain management and palliative care. And that leaves almost 6 billion people with virtually no access. Professionals who know how to appropriately administer them. To me, this is a crisis.
We all belong. We all belong to. We all belong. We all belong to. We all belong. We all belong to. So
Thank you very, very much, Dr. Pettus, for that incredible presentation. I'm honestly ashamed to say that I didn't know a great deal of the information there about the global healthcare trends in palliative care, and I really appreciate the time that you took with us. I would like to, there's lots of thank yous in the chat right now, but I would like to invite anyone that does have questions to add them to the chat. I will touch on the first one, being, is it possible to teach these countries how to localize their medications for their needs using their natural resources?
Thanks for that question. That's one of my fantasies. I've tried, and I will keep trying, especially as we negotiate this pandemic treaty, which is something I didn't say at the end that I want to, because this is the biggest thing we have on our agenda right now, is advocating for the inclusion of palliative care in this pandemic preparedness and response treaty that WHO is negotiating. And it doesn't include palliative care. It includes mental health, which is great. And of course, prevention, vaccines, diagnostics. But I entreat you to do a letter rating or some kind of email campaign or something. And I'm working on a one-page draft right now, which I'll send Monica and whoever wants it to advocate with the government of Canada to include palliative care in their negotiations for this treaty. Because it's not just palliative care we're asking to be included, just to address this question. It's shorter supply chains for medicines, including local cultivation and manufacture, because under the drug control treaties, and I've actually just submitted an article to a journal about this, most countries don't know this, that they can cultivate up to 5 tons of morphine a year for their own domestic use, under, of course, controlled conditions, without even having to report it to the International Narcotics Control Board. Of course, most countries will do that. But yes, technically it's allowed. Most people don't know it. We're trying to spread the word that it's allowed. But of course, the North American crisis has had a terrible impact on our advocacy for controlled medicines. And I was listening to Dr. Pereira's presentation earlier about the shortages of midazolam even, which is a controlled medicine under the drug controlled conventions. So, I mean, relying on India, China, and these really long supply chains for these medicines, it's just not realistic in the 21st century. We have to figure out new supply chains, local cultivation and manufacture. under the right conditions, and of course with a trained workforce. There's no point in flooding the market with morphine anyway, any more than there was with oxycodone in the States, OxyContin. You know, we know what happened there. Practitioners have to be properly trained. Administrators have to be properly trained. There have to be the rules, the infrastructure in place to allow it. But yes, it's allowed, and yes, we're promoting it.
Excellent. Thank you very much for touching on that and I guess just the challenges ahead in that sense. It seems like a simple solution, but unfortunately, there's a lot of gaps in the way. A question from Suzette. Do any systems currently exist where countries who have larger amounts and access to pain medications be shared with the countries who do have less?
No, it's not allowed at the moment. Well, access is a difficult term, and it's a technical sort of term of art, but yes, the countries that produce, which are the Northern European, Australia, we saw in the short film, Spain, they produce it, manufacture it through the pharmaceutical industry. But again, as we saw in the video, it's too expensive. Could there be a donation program? Absolutely. Are countries willing to do it and engage in all the kinds of paperwork and bureaucratic wrangling with what's called the drug control architecture? That's not my word. It's a term from the international system. Yes, they could do it. And it happens in small amounts all the time. For instance, we have a colleague in Sudan, and they get their morphine from Italy through the Comboni missionaries who have a mission in Sudan who support palliative care. But you have to fill out all the forms for import and export. It's quite complicated. Everyone's worried at the receiving end, especially in lower and middle income countries, about allowing controlled medicines into the country. The WHO has an emergency medical kit, which it sends to places, for instance, like Pakistan during the floods or the earthquakes, or to Haiti, or to Syria, or to Ukraine, and many countries, not Ukraine, hopefully, because they're quite advanced in palliative care, take out the controlled medicines that have been donated at the border, out of the emergency crates, because they don't want controlled medicines coming into the country, period, because they think they'll get into the illegal supply chain. There's still this opioid phobia, which I've written about elsewhere, and I think I have a chapter in the book about it, which is just everywhere. It's virulent, but we have to chip away at that too. But yeah, long answer to a short question. It's, again, technically possible. Do people want to engage in it? Rarely.
Thank you for that difficult answer to an even more difficult question, although it should be easy as well. We have another question, and it first comments that you used a lot of spiritual terms like metanoia, grace, and compassion. So their question is, what do you see the role of spiritual care practitioners within the global palliative care movement?
Absolutely key. In fact, people had to fight to get spiritual into that 2014 resolution at the WHO, which we consider our cornerstone resolution, because there's so many different ideas of what spirituality is. And of course, no one wants religion to be imposed on them. People identify spirituality with religion, but especially in what's called the Global South, faith leaders are the powerhouse, as a colleague of mine said the other day, of the community, and getting faith leaders on board for this is going to be absolutely key to generate the political will we need to get palliative care into the public sector. Because right now, the palliative care that is being provided in most of the developing world, as it used to be called, the Global South, whatever you want to call it, is being provided by often faith-based organizations, the Catholic Church, orders of sisters, orders, like I said, in Sudan, an order of, I think it's monks, really fathers, Comboni fathers, And in Hospice Africa Uganda, which is the teaching institute, especially for sub-Saharan Africa, was founded by a Benedictine, a woman who was, she's no longer a Benedictine, a nun, medical missionary of Mary. The Catholic Church runs 60 to 70% of all healthcare institutions in lower and middle income countries, and the evangelical churches also run them. Mosques, imams need to be gotten on board. In 2017, 2018, pre-pandemic, the Maruzza Foundation in Rome hosted a meeting of global faith leaders on 2 separate years. I think they were with 2 years apart, to sign a global charter of religions for palliative care for children. And then 2 years later, we came back and did palliative care for older persons, that's signed on to by all religions of the world. It's called the Religions of the World Charter, so you can look this up. Religions of the World Charter for Palliative Care for Children and Older Persons with Maruzza, that's in Rome, the Maruzza Foundation. So they're absolutely key. And this work is spiritual. It's if I want to put my spiritual hat on, it's bringing in the kingdom. That's what we're doing.
Thank you very much, and thank you for sharing that the charter with us as well. I feel that that would be a very interesting piece to look at, and also for spiritual care providers. Julia has a question regarding one of your comments towards the end of your presentation. You mentioned at the end the difference in funding between palliative care versus the global euthanasia movement. Can you speak to that some more as to what might be going on? And is the latter also restricted to the drug control conventions?
The latter?
Sorry, is the latter also restricted under the drug control conventions?
You mean our advocacy?
I
Or
believe
euthanasia? So, euthanasia.
Euthanasia,
No, they don't mention it. No, it's just that has to do with availability of controlled medicines at the national level and all the bureaucracy that surrounds that. And that's a whole subject in itself, which I teach on at our advocacy course, which is online on our website for members. But to go back to the funding for the assisted or administered death movement, which is a global movement, yeah, the funders, it's very well funded in Australia, Canada, Colombia. I don't know about the US, other countries. We operate on a shoestring budget. Funders are very unwilling. Most philanthropic funders, for a while, we had very good funding, but after COVID, that dried up, and we're looking for more. Of course, most of our funding comes from our membership, but in terms of what philanthropic funders are looking for, they're looking for outcomes. And advocacy, the kind of advocacy we do, produces the advocacy outcomes I shared with you in terms of international law and agreed language and those kinds of things, but it doesn't. We can't show what are called outputs, that those of you who've written grants know, that a concrete cost-benefit analysis for a funder, it's not there. The funder has to be emotionally committed to palliative care. Often they're people who've gone through this personally, who've been touched personally like I was, and then they get involved. If it doesn't address their bottom line or their national their you can't call it goals of care for philanthropy, but their strategic planning, if it doesn't fit in, they're not going to do it. We're definitely an orphan in the global funding scene.
The last few of our questions, there's actually one in the chat and one that I wanted to pose as well, is just how to best proceed with best advocating for palliative care at the community level. And I related that to the flow chart that you gave us that kind of went from the bedside to the IAHPC, and how we could best kind of share what we're finding out in the community and how to advocate at that level as well.
Oh, absolutely. Well, I think to do what was shown all day in the presentations is how palliative care improves quality of life. Not only do we have scientific evidence that it also extends life. There's quite a few studies showing that now, beginning with the breast cancer study a few years ago, but that it improves the quality of life for caregivers. It improves if you do it. Hi, I'm talking everything in my presentation, in my book, and what I'm saying now has to do with best practice palliative care, because we know there are gradations in quality, but that best practice palliative care provided by an IDT can really improve the life of the patient and family, as well as the community, because it often then allows, if it's provided early, upstream at the time of diagnosis, allows patients to participate in family, in work, in the faith community, in the political community, however they participate. It allows them to sit up and participate, unlike if think counterfactually, to use a political science term, if there were no palliative care, they wouldn't be able to participate. The family would be overburdened. And we all know the biological effects of stress and disease, how it creates more disease. So this is why I see it as evolutionary, because it's like stem cell therapy for the family, the patient, and the community, because it can regenerate the community. And the compassionate communities movement is one of the most interesting movements that exists right now. Many ways to advocate for it, especially providing support networks for those who are vulnerable and living alone, older persons, usually people with disabilities in your community. They often need a lot more than clinical care. They need spiritual and social care.
Absolutely. And I think that we all, well, I certainly learned that new word today, metanoia, and just knowing that that's perhaps the feeling that everyone attending today has already felt, but hopefully we can continue to encourage in our communities as well. I believe that that is the last of the questions that we have posted in the chat right now. So I will go ahead and close this section of the presentation, and I'd like to thank you very, very much, Dr. Pettus, for your thoughtful answers and your taking the time to present to all of us today. It was incredible.